Hello, this is a lecture on high-intensity focused ultrasound for uterine fibroid. My name is Xin Yo. I'm based in University Hospital of Cologne in Germany. First of all, let's take a look at uterine fibroids. There are benign tumors found in 25 to 70% of women of childbearing age. They're most frequent benign tumor in premenopausal women, and globally, there's an increasing trend in terms of incidence and also prevalence as well. They're non-life-threatening, however, they're symptomatic and they can affect quality of life. Patients experience menorrhagia, dysmenorrhea, pelvic pain, increased urinary frequency, and infertility. There are different treatment options available, such as medication using GnRHA or PR antagonists, surgical options such as hysterectomy and myomectomy, or interventional radiology options such as UAE, RFA, or HIFU. High-intensity focused ultrasound HIFU. It's a thermal therapy where we non-invasively heat the tissue using an extracorporeal transducer. At the focal spot, ultrasound will interact with the tissue, causing vibration of the molecules, leading to energy absorption and temperature elevation. When temperature gets elevated, we can control it to tissue ablation, which is more than 60 degrees Celsius, or around hypothermia range around 42 degrees Celsius. Hypothermia is a sensitizer for radiation therapy and chemotherapy and can be used to trigger drug delivery. Within the context of this lecture for treatment uterine fibroid, we'll be talking about tissue ablation. There are different commercially available HIFU systems. They can be MR guided or ultrasound guided. The Solif MR HIFU system and the XLB 2000, they are MR guided system, whereas the LPS 900, JC 200, Pro 2008, and HIFU Unit 900, they are ultrasound guided system. And these different commercial systems have received regulatory approvals across different continents, different regions around the globe, ranging from North America, Europe, Asia, South America, Oceania, and Africa. Let's take a look at the uterine fibroid treatment through the workflow. First of all, patient selection. There are a few things to think about when we select our patients, starting from symptom improvement. Will the patients get a lot of symptom improvement after the treatment? What is the ablation possibility? Are we able to ablate more than 80% of MPV ratio? MPV is non-perfuse volume. We'll come back to that in our next slides. Can we reach the fibroid? Are the fibroids accessible or not? Are we able to reduce the fibroid reduction? To reduce the size of the fibroid. Let's take a look at symptom severity score. In this study, where 252 patients were treated, symptom severity score, if you have a baseline score, which is severe, you see a huge decrease at 9.4 months follow-up. If you have moderate symptoms, you see a moderate decrease at the follow-up time point, and if you have mild symptoms, you have a smaller decrease at the average follow-up time point of 19 months. The other thing we look at when we select patients is T2 signal intensity. What you're looking at is a Funaki classification, type 1, type 2, and type 3. Type 1 fibroids have signal intensity less than the skeletal muscle. Type 2 fibroids have signal intensity between the myometrium and the skeletal muscle, whereas type 3 fibroids is brighter than the myometrium. Type 1 and type 2 fibroids are easier to treat, whereas type 3 fibroid have high smooth muscle content relative to collagen fibers. They're more difficult to treat. We also select the patient based on a T2 rim. So if you look at the image over here, T2 rim is associated with dilated lymphatic vessel, dilated veins, and or edema. In the top right-hand corner over here, you have a fibroid without a T2 rim, that you get very nice non-perfuse volume, which is an indicator of tissue necrosis after the treatment. However, when you have a T2 rim over here, which is this hyper-intense region surrounding the fibroid, you have poorer quality of MPV. If you look at the graph over here, we've shown that the MPV ratio is higher when there's no T2 rim. However, it's lower when there's presence of T2 rim. This knowledge allows us to adapt our treatment strategy. As you can see in the lower corner over here, if you have fibroids without a T2 rim, you can have minimal overlap between the treatment cells or the treatment focused. If you have a fibroid with a T2 rim, you apply a more aggressive treatment strategy where you have a high overlapping treatment cells to ensure good treatment outcome. Next, we take a look at perfusion. So dynamic contrast enhanced MRI, DCMRI, is also used to assess the fibroid as well. The higher K-trans value is associated with reduced ablation efficiency. If you have a relative peak enhancement of less than 220%, you will have a better ablation efficiency compared to RPE of more than 220%. There are different studies that also look into how you can combine this different selection criteria into a mathematical model for patient screening. This is an example of a generalized estimating equation analysis where it takes into consideration of subcutaneous fat thickness, the relative peak enhancement, and the T2 signal intensity. And the immediate therapeutic response is assessed by using ablation efficiency or ablation quality. As you can see in the figures over here, the ablation quality, grade 1 is you have very poor ablation quality, very poor MPV ratio, and grade 5 is you have very good MPV ratio. The cutoff values for therapeutic success, where efficiency is defined as 1, quality is grade 4 and 5, ablation efficiency is about 1.3, ablation quality is about 4. So, now that you selected your patient, what can you do before the treatment? Something we can do is to prescribe the patient with GnRHA. GnRHA, after prescription, studies have shown that leads to reduction of the fibroid volume and T2 signal as well. Then this would affect your energy delivered and also help increase the MPV. As you can see on the table in the top right-hand corner, a comparison between the group receiving GnRHA versus the control group, you see that the mean energy delivered is less compared to the control group. And the MPV per joule for the study group of GnRHA is higher compared to the control group. Studies have also shown that at 3-month follow-up time point, there's a volume reduction of 36%. The images on the lower left-hand corner over here is at 1-month treatment follow-up. So we see that there's almost a 60% signal intensity reduction at 1-month follow-up after application of GnRHA. So on the lower right-hand corner over here, we're looking at a significant reduction in signal intensity after GnRHA prescription, and then also reduction in volume as well after GnRHA prescription. So now that you selected your patient, you prep the patient before the treatment, now it's time to do the treatment. One of the first things we need to ensure is we need to have acoustic access to the fibroid. There are different ways to establish acoustic access. One way is by doing the BRB, which is a bowel removal technique, which starts with bladder filling, followed by rectal filling with ultrasound gel, followed by bladder emptying. If you look at the images directly below, figure A, where the arrow is pointing, show bowels in front of the fibroid labeled by F. Figure number B show that after bladder filling, we're able to move the bowels away. And then we follow by rectal filling, and then we reduce the volume in the bladder. And in figure D, you can see that we're able to establish acoustic access to the fibroid. Other ways we can do is by compression method using a wedge gel pad. As you can see in the images below, the wedge gel pads were delineated in red. You can see by adding the wedge gel pad is actually in green, and then the red part are the bowels. So by applying the wedge gel pad, we're able to move the bowels outside the beam path. The other method to do that is by using water balloon to compress the bowels away. So next, we mentioned that we can do MRI or ultrasound guidance. So MRI is excellent for soft tissue contrast. Temperature and thermal dose are being used as readout during the treatment. Here's an example, a placement of a treatment cell on the fibroid. And this in the middle image over here, we're looking at temperature increase at the treated spot. And then immediately after the treatment, we're looking at the non-perfused volume as a result of the treatment. We can also do ultrasound guidance as well. Ultrasound guidance is very good for real-time imaging, and during the treatment, the change in tissue echogenicity is being used as a readout for tissue ablation, as seen in the figures below over here. Next, let's take a look at an example of a treatment monitoring using MRI, which provides you with temperature information. Let me start the video. What you're looking at are 4 different panels. This is the coronal plane at the focal spot, the sagittal plane at the focal spot. This lower panel is in the near field, and this other panel over here is in the far field. The near and the far field temperature information allows you to monitor what happened around the vicinity of your treatment cells. And then this is an example for a Sonlife MR HIFU treatment. What you also see over here, let me try to restart the videos for you as well. What you can see is a feedback cell. The Sonlife MR HIFU system comes with a temperature control feedback loop. What it does is it allows physician to place a treatment cell, start the sonication, and then with the temperature control feedback loop, the sonication will automatically be stopped when the desired thermal dose has been achieved. So the system has the temperature resolution about 1 degree Celsius, spatial resolution about 2.5 millimeter, and temporal resolution of 3 seconds. So how can we use this temperature information now that we have them? What we're looking at is the temperature decay rate, which is being highlighted in a box over here. If you have a temperature decay rate of 0.23 degrees Celsius per second, a peak temperature about 69.3 degrees Celsius, the outcome of your treatment, as you can see in the top panel in the right-hand most corner, very good MPV, high MPV ratio after the treatment. However, if you have a temperature decay rate of 0.5 degrees Celsius per second, the peak temperature about 59.4 degrees Celsius, you can see that the MPV after treatment is rather poor. When you see that during the treatment, you can immediately adapt your treatment strategy. This is example what we can do. If you have a temperature decay rate of 0.23 degrees Celsius per second, we can have minimal overlap of treatment focus or treatment cells for well-responding tissue, such as this one. However, if you have a poorly responding tissue where the temperature decay rate is about 0.5 degrees Celsius per second, then you need high overlapping treatment cells or treatment focus to make sure that you treat it aggressively to ensure a good therapeutic outcome.